Maria Vogiatzi, Children's Hospital of Philadelphia. CAH is a congenital disease, and it is a disease that has to do with a defect in adrenal steroidogenesis. As part of this disease, patients cannot synthesize cortisol, cannot synthesize aldosterone, and everything is shifted towards the pathway of adrenal secretion. As a result, the affected babies, the female affected babies, are born with virilization of the external genitalia, and as a result, they are easily identified at birth. However, males are phenotypically perfectly fine, so they are frequently missed, and they may present later, like in the second or third week of life, with severe dehydration and salt wasting crisis. So what happened, the newborn screening for CAH was kind of expanded in the United States in the 80s and 90s, and led to the early identification, the early diagnosis of the disease. And this was a significant milestone in CAH because mortality was reduced significantly. Now, the newborn screening is newborn screening, so as any other screening method, you're going to have false positives and false negatives, and as long as people realize the limitation of the testing, that's great. But overall, newborn screening has contributed significantly in reducing the mortality in CAH. So if we move away from this presentation, some kids may get missed during newborn screening and present a little bit later with problems such as growth acceleration and early puberty. And finally, people have to realize that CAH is a spectrum. There is the severe spectrum that I just described to you, and there is also a mild phenotype of the disease that is frequently referred as non-classic CAH that has some kind of androgen excess, but adequate cortisol secretion, and these people present later on in life, or can actually be asymptomatic throughout their life and miss actually medical attention. CAH, as I discussed, is a defect in the way that cortisol is synthesized. So the main treatment therapy for CAH is essentially glucocorticoid replacement. Glucocorticoid replacement, of course, replaces the cortisol that the individual is missing, but it also has another function, and that is to reduce the ACTH drive because of CAH, and therefore reduce adrenal androgens as well. The trick with CAH is that we have to use supraphysiologic doses of glucocorticoids to suppress ACTH secretion and suppress adrenal androgens. So the doses that we use are typically higher than the doses that are used in adrenal insufficiency. This use of glucocorticoid doses at supraphysiologic doses in CAH has also led to a number of comorbidities, and children and adults with CAH have frequently increased body weight. They have signs of metabolic disease such as insulin resistance and dyslipidemia. Hypertension is quite common and can also be linked to high doses of glucocorticoids. So it is not a happy story. CAH is characterized by androgen excess, and androgen excess leads to rapid growth during childhood. So the child looks like, if you look at it, looks like it's growing fine, but this nice growth rate happens at the expense of significant advancement in bone age. In other words, this high advancement in bone age kind of narrows their window for growth and their growth potential. Then what happens once we have a pattern of rapid bone age progression. We are worried that height outcomes are compromised. What we typically do is we try to increase the doses of glucocorticoids in an effort of suppressing these excessive adrenal androgens. However, going up on glucocorticoids can also cause problems because glucocorticoids also have a negative effect on growth rate. So what you see in these children, you see accelerated growth during childhood with significant advancement in bone age. Their pubertal growth spurt is blunted. In other words, they don't have an appropriate growth during puberty, and then they reach adult height earlier than you expect, and as a result, they have an adult height that is reduced compared to the general population. And despite all treatments with glucocorticoids at the moment, the mean adult height for CAH remains about 1 to 1.4 standard deviations lower than the population mean. The growth is proportionate. It's just that you see a really tall kid for age looking older than his actual chronologic age, but it's not a disproportionate growth. In this meeting, we were excited to have the results of a study that look at the effect of Crinecerfont on growth in children with classical disease. The children were initial participants in the Catalyst pediatric study for Crinecerfont, and then went into an open label extension and received treatment for up to 2 years. So we have the growth outcomes of 2 years of treatment with Crinecerfont. The study included 41 children, and a number of them had a significant advancement in bone age, and as a result, their height potential was compromised. So their height looked good. Their height adjusted for bone age was decreased, and Crinecerfont was found to reduce the bone age advancement. In a subgroup of 9 children, the bone age progression actually was halted over the course of 2 years, and as a result, the growth outcomes improved significantly. Remember, in these children, the problem is not the actual height, but it is how the bone age affects their height potential. So the height during the study continued to be in the same percentile. Actually, these are usually tall children, but because they have an advanced bone age, their height adjusted for the bone age is low. So what you saw during the course of the study, the height remained the same, but the bone age didn't change, and as a result, they sort of recover some of their height deficit, which means that their height adjusted for their bone age got better. Bone age is an X-ray of the left hand. It looks at the epiphyseal centers, and you compare the bone age of a child with standards that are images essentially in a book that is called Grellich Pyle. The clinician needs to match the child's image with a standard in the book, and you assign a bone age doing this comparison. Well, since we're talking about data coming out of the Catalyst study, and we started having 2-year outcome results for children, I have to say that all these benefits that we saw in growth happen in the phase of glucocorticoid reduction. So Crinecerfont was effective in reducing daily glucocorticoids. And yes, there was benefits in growth, but there were also additional benefits. So we have some data trickling in to indicate that after 2 years of treatment, BMI also goes down, and it decreases more significantly among those who are overweight. So there may be complementary benefits to this treatment. So let's go back at the pathway of CAH. As we said, CAH is a block in cortisol secretion, and as a result, the ACTH secretion from the pituitary is very pronounced. And glucocorticoids, again, the treatment, the goal is to reduce these elevated ACTH levels. Crinecerfont works one step higher. It blocks another signal that regulates ACTH secretion. The hormone is called CRH, and crinecerfont blocks the CRF receptor for CRH.